airway and chest tube. Oftentimes a thoracon. A simple pneumothorax. You guys, I don't know if you can see it with this lighting here. Normal? Up there. See how it's dark here? Right there. You can actually see the outline. So we talked about that before. There's a ventilation perfusion defect. You can have some hyperresonance or decreased breath sounds on the affected side. And patients need a chest tube. There's some thought to manage some patients expectantly without chest tubes, but that's it's a little advanced and controversial. Pulmonary contusion. Relatively common, especially with middle rib injuries. So how do you treat them? Oxygen, ventilation, pain control, selective intubation if this patient's going to be transferred, or certainly if this patient's going to be in a helicopter, probably going to need to be intubated. The problem with this is that on initial physical exam, primary, even secondary survey, it's hard to pick up. Initial chest x-ray is sometimes hard to pick up, oftentimes better picked up on CT scan. Hemothorax. So chest wall injury, some of the smaller rib vessels or lung vessels, and maybe a chest tube. Cardiac contusion, blunt cardiac injury. It's a tough diagnosis, mainly because there hasn't been a true consensus on what constitutes a cardiac contusion. Okay? What are we most worried about with cardiac contusions? And it's not the heart blowing up or rupture. What do we watch for?
Lack of circulation.
Somewhat. But what's one of our initial interventions or investigations? It's an EKG. Why? Are we looking for an MI? Which can happen, but it's less common. We're more looking for arrhythmias, right? So that's the key thing. We're looking for arrhythmias, or dysrhythmias. And it's tricky. It's tricky to pick up a cardiac contusion. You can sometimes pick it up on EKG or cardiac enzymes or echocardiography, but it's a sort of a squirrely diagnosis. Traumatic aortic disruption, so a tear in your aorta. A traumatic tear in your aorta is a very bad prognostic sign, right? Where does the aorta tear when this happens? Okay, well, actually, let's step back. How does this usually happen? It usually happens from a fall from a great height or an incredible deceleration injury, right? And so where does the aorta tear? At the arch, right? Where the ligamentum holds onto it, right there. So sort of where it's tacked down, and then when you have that deceleration injury, that holds tight, and then your aorta goes flying towards the windshield. So there are a couple of X-ray signs, and the famous one is wide mediastinum. But it's a tricky one to make without advanced imaging, usually CAT scan. A lot of these patients don't survive to make it to the hospital anyway. Okay? The ones who do make it usually have contained hematoma. Because if you think about it, if you tear your aorta and it's a real tear, you're not going to make it very far. Traumatic aortic disruption, you can even see that there's some contrast going down, sort of tunneling through the walls. It's a big hemothorax. A lot of inflammatory changes. Blunt esophageal rupture. Anyone know what a medical esophageal rupture is called? Remember that? Named after Sir Isaac Boerhaave. Actually, I don't even know if he was Sir Isaac. It was some guy Boerhaave. But so Boerhaave syndrome, which is esophageal rupture, and a traumatic esophageal rupture, just the same thing. You have a traumatic blow, usually to the epigastrium, and that pressure is basically transmitted to the esophagus, and you have a blowout of the esophagus. It is a high morbidity and mortality. This condition has a high morbidity and mortality. You put a chest tube in, sometimes get some stomach contents out of that chest tube. So these patients need to go to the OR. Diaphragmatic injury. This is a somewhat of a tricky diagnosis to make, especially in penetrating trauma. blunt trauma usually leads to large tears of the diaphragm. Okay? And why are diaphragmatic tears usually on the left? Why does this usually happen on the left? What's on the right? Yeah, so the liver gets in the way. It's actually protecting the diaphragm. Okay? So the liver just gets, you just get a liver laceration instead of a diaphragmatic tear. But on the left, you can actually have a pretty large diaphragmatic tear. Blunt diaphragmatic tears can be pretty large, but penetrating injuries can oftentimes cause small lacerations, and these often are not found on X-ray, and often are missed on CT scan as well. So these are tricky trauma patients to deal with, because you have to have a decent index of suspicion to look for this injury. It's missed on X-ray, sometimes missed on CAT scan. CAT scans have really evolved over the years and have really become a big part of trauma care, whether we like it or not. And the purists will say that it's sort of a bad thing, but most of the patients who are trauma alerts get at least a few CAT scans. CAT scans of the abdomen famously miss diaphragmatic tears as well as a small bowel injury. Okay? They're very good at looking for splenic injuries, very good at looking for liver injuries, but small intestine and diaphragm are still sort of a black box. Traumatic asphyxia. So why does this guy have all petechiae all over him? Why does he look like plethoric? Why are his eyes bulging? So he was crushed by a car, say, or crushed by, I don't know, a big weight. He was working out, and he got pinned under the bar. He was doing a bench press, and he got pinned under the bar. So why is he all bloated?
Blood has no way to return.
Right, exactly. So basically, he had essentially like a super vena cava syndrome, right? So there was compression on his vena cava, and now so basically he had all these small petechiae and swelling and even cerebral edema. This guy has subcutaneous emphysema. You can have this from a blast injury. You can have this from an airway injury, and you can have this from an iatrogenic cause. In other words, when 8 people are taking a look and trying to put a tube down and causing some trauma, or if we're even trying to bag too vigorously, you can have this. So I've seen people have sub-Q emphysema just being on BiPAP or CPAP. Fractures, rib fractures. Ribs 1, 2, 3. First rib fractures, scapular fractures, they're important to know about, for sure. Right? They're painful, but even more so, you worry about what? What sits right next to the first rib, which is really pretty deep in your thoracic cavity.
Subclavian veins.
So your veins, your major vessels, exactly. Your major vessels are sitting right next to it. Your subclavian, your vena cava, your aorta, depending on your side. So a sternum fracture, a scapular fracture, or a first or second rib fracture, you really got to worry that there's some other injury going on. Okay, so they're more of a sign of something else going on. Ribs 4 through 9, associated with pulmonary contusions and pneumothoraces, and these are the most common rib fractures. And the ribs 10 through 12, again, you worry about some other injuries, right, because of their location. Like what organs you worry about? Exactly. Good. So simple pitfalls. Simple pneumothoraces can convert to tensions. Retained hemothorax, not necessarily our deal here in the field. Diaphragmatic injury, again, something that you have to have a high index of suspicion for. Severity of the rib fractures, right, and flail chest, not necessarily the worrisome about the fracture itself, but the underlying pulmonary pathology. And then extremes of age, always tough down here. Questions? So in summary, thoracic injury is common in multiply injured patients. Remember to look for the life-threatening things that we can do something about immediately, right? Tension pneumothorax, pericardial tamponade, massive hemothorax, airway obstruction. And again, the majority of these injuries, all thoracic injuries, can be handled with intubation, fluids and blood products, and then chest tube. Okay. Thanks for your time.